Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our tumor board. And I'm going to ask our esteemed panelists if they wouldn't mind going ahead and introducing themselves. We'll start out with Dr. O'Shaughnessy.
Hi everyone. Joyce O'Shaughnessy. I'm in Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas, and I'm a breast medical oncologist. Very nice to be here with you today.
I am Dr. Frank Piccini, radiation oncologist with Genesis Care in Michigan.
Hi, I'm Norman Woolmark. I'm professor of surgery at the University of Pittsburgh. I'm chairman of the NSABP Foundation and co-principal PI of NRG Oncology.
I'm Maxine Jockelson, and I am a professor of radiology at Memorial Sloan Kettering Cancer Center, where I direct the imaging for the Breast and Imaging Center. I'm primarily a breast imager with a little sideshow of doing PET scanning as well.
57-year-old Caucasian female that has a clinical T2N0 left invasive ductal carcinoma, grade 2, ER and PR positive, and HER2 negative. She completed neoadjuvant chemotherapy with docetaxel and cyclophosphamide, followed by left breast radioactive seed localized lumpectomy and left sentinel lymph node biopsy. The question that's being raised is, could re-excision of a close ductal carcinoma in situ margin be recommended prior to proceeding with adjuvant breast radiation therapy? So we'll go into some of the details of this particular patient. She had presented for routine mammogram, no breast complaint. So this was a screen-directed malignancy. She has an excellent performance status. Her medical history, really not significant at all. Menarche at age 13, menopause age 50. She is G0. Oral contraceptive use for 20 years with no hormone replacement. No significant alcohol or drug use at all. Family history significant for breast cancer in a maternal aunt, multiple myeloma in her mother, and prostate cancer in her father. Again, in October of 2020, she underwent bilateral screening mammogram, which demonstrated architectural distortion in the left breast. And we have some images here in just a bit. Dr. Jockelson will kind of walk us through that. In November, then she subsequently underwent left ultrasound core biopsy that showed the invasive ductal carcinoma grade 2, ER and PR positive, HER2 negative. Bilateral breast MRI was subsequently completed, and this demonstrated the left breast mass measuring 2.6 centimeters with a little bit of non-mass enhancement anterior to the mass, in total 4.2 centimeters, and no axillary adenopathy was seen on the breast MRI. So Dr. Jockelson, if you wouldn't mind walking us through the imaging findings.
Certainly. So the first image is an MLO and craniocaudate view of the left breast. And in the upper outer quadrant, I probably would have described it as a focal asymmetry rather than architectural distortion, but everybody has a different way of describing some of these findings. And certainly that is suspicious for malignancy. I don't have the ultrasound, but I have no doubt that they did find a lesion there. And then on the next slide, you can see her MRI, and it looks like a subtraction view with all the background parenchymal enhancement subtracted out. And you can see that there is a 4.6 centimeter area, and that looks like the non-mass enhancement that we see there. So it's hard to define the size on mammography. Ultrasound notoriously underestimates the size of tumors. MRI, if anything, may overestimate, but is a more accurate depiction of the extent of disease, especially because non-mass enhancement often is not demonstrated on the ultrasound. So I think this does give you a better description of the extent of disease locally.
Okay, thank you so much. So moving on with her case, in March of 2021, she completed neoadjuvant docetaxel and cyclophosphamide for 4 cycles. In April of 2021, she underwent the radioactive seed localized lumpectomy and sentinel lymph node biopsy. And this showed a 0.7 centimeter residual invasive ductal carcinoma, grade 2, ER and PR positive, HER2 negative, residual cancer burden index of 1. There was some DCIS present. There were 2 lymph nodes that were identified that were negative for carcinoma. The margins were negative for invasive cancer, all of which were greater than 0.2 centimeters, However, the margin for DCIS was less than 0.1 centimeter at the medial margin. So Dr. Woolmark, do you want to kind of walk us through how you would approach someone that has this pathology report?
I've always been intrigued by the debate as to margins, particularly as related to DCIS. I mean, we're at complete equipoise in accepting a free margin as defined as no ink on tumor cells for invasive breast cancer. And yet for DCIS, we have interminable debates. I was at a national conference recently where the entire afternoon was devoted to 1 versus 2 millimeter margins for DCIS, which makes absolutely no sense whatsoever. I mean, this patient had a very reasonable objective response with neoadjuvant therapy, has a residual 7 millimeter invasive carcinoma with some incidental DCIS that also had a free margin. I would certainly leave it at that. I would not go back to re-resect this. I know there are surgeons who certainly would. I would not. I think it would make absolutely no difference and would expose this individual to a procedure that would have no salutary benefit, and then go on to the course which would involve radiotherapy. And if we're concerned about the DCIS margin, I think that the radiotherapy will be more than adequate to deal with it. And that's my homage to Frank Vicini as well.
I guess that's my lead-in.
Yes, perfect.
No, I totally agree with Norm, although there is this debate about DCIS margins, right? For pure DCIS, should it be 1 or 2 millimeters or 2 millimeters? You know, for the most part, I would radiate this patient, would not push for a re-excision. What I would do is kind of get a little higher booster dose, if you will, to the lumpectomy cavity region. The only scenario where I would really push for a re-excision, and this is kind of from my own practice and from some of the studies that we have done, if there was a significant amount of DCIS near that less than 1 millimeter margin, right? Not all margins are the same. That's kind of where I differ perhaps with Norm. In other words, if there's 3-4 millimeters approaching less than 1 millimeter, I might, in talking with the surgeon, if there was not a poor cosmetic outcome with doing that, I might push a re-excision. But for the most part, I'd be very comfortable treating this patient with radiation therapy and just giving a slightly higher booster dose to that area.
Perfect.
I agree with the debate on margins. I mean, this was one isolated margin. So the argument that there are multiple areas involved less than a millimeter is not applicable to this particular case.
Right.
So Dr. Woolmark and Dr. Vicini, can I ask you, would your thoughts be different in this situation? You know, Dr. Vicini, you already raised the question, if there was a more extensive area of this very close margin, you might feel slightly differently. But what if this was a patient with pure DCIS? What if this was just DCIS, there was no invasive cancer, and you have this medial margin that's fairly close? Dr. Woolmark, would that change your thinking about this at all, or would you approach it in the same fashion?
Not one iota would it change my thinking. And we do have some data where B24, we did allow individuals whose margins were involved. The number of cases that we went back for re-excisions and found nothing, I think provided a lesson. I think the 1 versus 2 millimeter margin in many instances is synthetic and not data driven. I would not alter my approach.
Perfect. Thank you so much for that. And Dr. O'Shaughnessy, if you might just comment for us, the question hasn't been posed, but just curious how you would approach this patient that had 4 cycles of docetaxel cyclophosphamide in the neoadjuvant setting, and then, you know, has a relatively good response, residual cancer burden index of 1, but not a pathologic complete response. How would you approach her adjuvant therapy?
So I would, I think she had a really remarkably good response, actually one that I was surprised at, and I'll make a comment on that in a second. But given where we are right now, I would recommend 5 years of an aromatase inhibitor to her. Perhaps in 5 years, we'll have a very well established, genomic predictor of whether she could stop, at that time. But being that she's node negative, but an interesting area of evolution, I think, is the postmenopausal ER positive patient who desires breast conservation. The T2 lesion, let's say, here is a little too big, to have an excellent cosmetic outcome. So she wants, downstaging. She wants cytoreduction. How do we best do that? Do we give her preoperative chemotherapy? Do we give her preoperative endocrine therapy? So, she had an ER/PR positive breast cancer, was grade 2. So do we send one of the genomic predictors? And she's postmenopausal. We know from both Taylor X and Responder that if she comes back in the less than 25 range or the low risk range for the 70 gene or the 21 gene predictor, that she's not going to get a systemic benefit, or very little, if any, systemic benefit from chemotherapy, adjuvant chemotherapy. Nonetheless, she might still get some downstaging. So, just yesterday, I had this conversation with a woman, and we actually decided, very similar scenario, to actually send a 21 gene recurrence score. And I told her that if it came back, within less than 25, I was going to recommend just an aromatase inhibitor. And I actually wanted to do like the ADAPT, pretend I was German here for a little bit, and either at 2 weeks or at 4 weeks, ask the surgeon if they wouldn't mind doing another biopsy, and we could look at that Ki-67 and get some dynamic information, because it really did seem to predict for doing very well without chemotherapy. How long do we give the endocrine therapy for? I think until as long as you're getting good results, and she's clearly having good reduction, getting towards her goal of, breast conservation. So it's interesting. I think we're in evolution now. You can't argue with this woman's success. I think she's had a fantastic result, but it is something, we get the Ki-67, if it was 50% on the Ki-67 grade 3 breast cancer or something, for sure, I'd be looking at some chemotherapy for her. But if she was in that gray zone about whether chemotherapy would be a benefit, I might send a gene predictor and consider endocrine therapy for her preoperatively.
Thank you so much for your insights. So for this particular patient with hormone positive, HER2 negative invasive ductal carcinoma with associated DCIS, we would not recommend re-excision of the close DCIS margin, and recommend going ahead and just proceeding with planned adjuvant radiation therapy, followed by 5 years of an adjuvant aromatase inhibitor, with consideration of extending endocrine therapy pending the results of genomic assays available at that time.